Hi there, my name is Vic Veer. I'm the head of the sleep surgery department at the Royal National ENT Hospital in central London. And my job on the NHS is to help people with obstructive sleep apnea. Now I try and take a very sort of holistic view if I possibly can with other devices and things like that. Anything but surgery, but some people do need surgery. And when it comes to surgery, I have about, say, 38 to 40 different operations I could do to help people with obstructive sleep apnea. But obviously I can't use them all on every single patient. That would just be horrible. What I need to do is pick the right operation for the right patient. And then the question therefore is, how do I pick the right operation? Now, I guess you could just look in someone's mouth or use that telescope up people's noses to look at the back of the throat. But if you've got obstructive sleep apnea now, watching me now, and I did that to you, well, you're awake now, or hopefully awake now. You haven't fallen asleep listening to me, but you're awake now. So you're not snoring, you're not having sleep apnea now. So what will I see apart from a relatively normal throat, unless you've got big tonsils or a blocked nose or something? So it's useful, but not really that useful. What would be really useful if I could watch the back of your throat whilst you are sleeping. So the way I do that is this investigation called a Drug Induced Sleep Endoscopy. What this is that I bring you into hospital, I lie you down on the bed, and I give you a touch of anaesthetic so you just start sleeping in front of me, so I can see the back of your throat. With that little telescope I was telling you about, I look at the back of your throat, videotape the back of the throat, so I can see where the flutter and the noise is coming from, where the stricture, the obstruction is coming from, which is causing the sleep apnea. And then I wake you up and show you the video and say, look, this is what I found. Your problems are A, B, and C. And here are the devices, the exercises, the operations that would fix that. And then your job is to choose out of the 2 or 3 operations that would work, that you think you could tolerate, and we go ahead and do those. Now, some people say to me at this point, now hang on, you're giving people anesthetic. That's not sleep, that's an anesthetic. And to be honest, I completely agree with you. I don't think that's a true reflection of their sleep. I think anesthetic is very different from sleep. So I know a lot of people around the world use the old technique where you give sort of boluses of this drug propofol to get people to sleep, and you sort of catch them as they're coming in and out. I don't particularly like that. Some people use an infusion, just tightly controlled infusions, to get them at that right level so they're snoring away. Again, I don't like that either, and I've done some research to say that actually what you see in that state is different from real sleep. The way I do it, which is I think different to a lot of people, is that I use the fact that propofol, this drug that gets people to sleep, it only sort of stays in your system for a few minutes. Well, it stays in your system for a long time, but it comes out of your brain within about sort of 10, 15 minutes. So if you give someone propofol, yes, they're anesthetized. It lets me get the telescope into the right place so I can start looking at the back of the throat. But then all I do is just wait. I turn off all the lights, keep the patient nice and warm and comfortable in the bed, give them oxygen, tell everyone to stop talking, make it very quiet and dark in the room. So as long as you don't wake them up in this state, they just carry on sleeping. As long as no one coughs or shouts out a name or the lights get turned on, people just carry on sleeping, because I think it's as close as possible to real sleep. Of course, there's a bit of an anesthetic effect there. It's as close as I can possibly get to. But the difference is that instead of me moving around or coughing and the patient just stays still because they're anesthetized, I can put the scope in and out. It doesn't make a difference to those sorts of people who are anesthetized. In this state, once you've let the anesthetic wear off and they're, I think, as close as possible to sleeping, if you called out their name or if you nudged them, patients often go, oh, I didn't mean to fall asleep. And they apologize for falling asleep, which is exactly what I wanted them to do. So what I saw just before they were woken up is as close as possible to as real sleep as they do at home, natural sleep at home, because they could be easily aroused and they wake up and they sit up and go, oh, sorry, what happened there? So that to me feels more representative of real sleep. And that's why I do it this way. The problem with this technique is it's much, much harder. It takes a lot longer and it takes a little bit more skill, keeping still for 15 minutes without waking these patients up. But if I'm going to do a painful, difficult operation on someone, I want to get the best possible evidence I can to say to this patient, look, this is what I really think is going on. And that's why I do it this way, because I just think if I'm going to do an operation on someone, I need to know what's going on exactly, or as close as I possibly can. Now, if you want to know more about drug-induced sleep endoscopy, I'll leave some videos here and here and here. And equally, I'll tell you about the classification system I use so people can understand what they're seeing down their throat, so they can differentiate what the different problems are at the back of the throat, because actually that's quite difficult as well. So I've invented a classification for that as well. So have a look at that video there. But for this video, thank you very much for watching. Take care. Bye-bye.